So what we say is that really age is just a number, but frailty is much, much more than just a number. So oftentimes, you could think in your mind's eye of an 89-year-old person that you know who's thriving in the community and is very healthy and functionally independent, but you could also probably think of a 67-year-old person who's quite dependent on others for day-to-day care. And what explains the difference between those two people is obviously not their age. It's much more than that, and I would say that it's frailty that you're noticing. So frailty is really how active you are, both physically, socially, and mentally. It's about how many medical problems that you have and how well you're able to do daily tasks in spite of those medical issues. Doctors use that term frailty to describe those things, and it turns out that frailty is a much better predictor of future health than age alone. And it also turns out that frailty is something that, through work that's been done at our geriatric medicine research unit with Dr. Ken Rockwood and Dr. Arnold Mitnitsky, turns out to be reasonably easy to measure, both by healthcare providers, but by caregivers and patients as well. So Dr. Rockwood and Dr. Mitnitsky developed something called a clinical frailty scale. And what it allows people to do is to look at their own mobility, function, and cognition that they're already aware of and place themselves on a scale of frailty, which runs from very fit, so that's somebody who exercises regularly, has few or no medical conditions, and has no cognitive impairment, all the way down through to severely frail. And that's when somebody may have severe cognitive impairment, may be bedridden or reliant on a wheelchair, and is completely reliant on other people for aspects of everyday care. So the next step in the path after understanding health status in a comprehensive way is communicating that health status to the individual and particularly the substitute decision maker. The reason for the focus on the substitute decision maker is that for any of us who become acutely ill, we're often unable to speak for ourselves in that critical time. So it's important to have the substitute decision maker understand the health status as well as be empowered to know how to approach medical decisions at 2 in the morning when they find themselves in the emergency department with the person that they're caring for. So in terms of communication, our aim is really to provide a very frank and honest description of a person's medical problems, dementia if it's present, what their current function is, and what to expect in the future in terms of each of their medical problems. We also look at how illnesses will impact not only life expectancy, but quality of life, what the symptoms might be that they might see over time. So if you look at the literature about how to communicate prognosis and approach care planning, what you find is that most of the palliative care literature really focuses on developing care plans through the use of open-ended questions. So you might ask questions like you see on the screen here. What makes life worth living with you, for you? What are your biggest fears? What would you consider to be a fate worse than death? So this care planning approach starts with these questions and then uses the answers that patients and their substitute decision makers provide to determine what further information that person needs in order to make a decision. And those values, or those wishes and hopes and values, are used to construct goals, which are used to construct these advanced directives, if you will. And really, our approach questions this approach that's found in the literature, and I'll just review some of our concerns. One of our concerns is that that approach assumes that patients and their families need us to integrate their values into their decision making. And I think we would all agree that every day we make decisions in life in which our values are implicit. We organize information, apply our values, and make decisions. So our approach is that in fact patients don't need us to tell them information based on their values. They need us to tell them information that they can then integrate into their values. We also challenge the idea that we need to wait until people are ready to have this conversation, because our experience has been that if we wait until people are ready to have a conversation about prognosis and care planning, we really may miss the opportunity, and many people can die, in pain with uncontrolled symptoms if this conversation is held off. We also challenge the idea that the basis for the interaction should be this ask, tell, ask model, where I ask you about your values, and then I tell you a little bit of information, and then I ask you further about values. Our approach is based much more on information provision, so it's more of a tell, where we give people the big picture and allow them to integrate their values into their choices. So the reason that, one of the challenges, as I said, is communication, and how even when we recognize that end of life may be near, we often don't really communicate that to patients and their families. So the second interaction or the second visit of the PATH process is dedicated exclusively to providing that information. We describe each illness and its prognosis. We talk about frailty, we talk about dementia, and we use language, for example, if appropriate, to say, well, your husband is approaching the final phase or the final chapter in his life. It's not about predicting how long that chapter will be, but just making sure that the care plan matches the overall prognosis. And we actually use a script, a loosely structured script, but a script nonetheless, to make sure that we go through all of the steps in an ordered fashion and that we don't shy away from having these difficult conversations. So after the health status has been assessed and that has been communicated to the patient and their caregiver or substitute decision maker, the next step is to really look at how that information can be used to make decisions. And that's the final step of the PATH. So this usually is a separate visit or interaction because there's a lot of emotional and psychological work that often needs to be done by the patient and their substitute decision maker between PATH visits. But the idea is that, we could talk about overall health issues and how those might impact on care decisions today, but really we can't anticipate every possible decision that will need to be made. So it's more about providing the skills that are needed to negotiate those decisions, and particularly at times of crisis. So that's what Visit 3 is really all about. And we use a framework for decision making for Visit 3. What we do is we actually think about, well, what are some possible scenarios that we could reasonably predict might happen to this person, some possible health crises. So for example, if somebody has advanced dementia, we know that that increases the risk of falls. And with falls comes the risk of, for example, hip fracture. So we might work through the scenario with the substitute decision maker of that individual having a hip fracture. And how would we approach what treatment is needed at that time? So some of the questions that are important to ask are, which health conditions are easily treatable and which are not? A hip fracture may be easily repairable, but the underlying condition that caused the hip fracture, the dementia, and possibly multiple other medical conditions, may not be easily treatable. Will frailty make treatment risky? Certainly, the more frail someone is, the higher the risks they face, not only during the surgery, but in the weeks after, in terms of how they may recover. How can symptoms be safely and effectively managed? Sometimes we think it's a decision of whether to treat or not to treat, instead of deciding whether it's to treat with one thing, such as surgery for a hip fracture, or treat in another manner, using medications for pain control, for example, without surgery. Will the proposed treatment improve or worsen function or memory? Will the proposed treatment require time in hospital, and if so, for how long? So that helps the substitute decision maker to think about the big picture and the impact upon one's overall quality of life and function that any intervention might have. Will the treatment allow more good quality years, especially at home? And what can we do to promote comfort and dignity in the time left? So I'm going to work through a case using these questions with you. So this is an example of a gentleman who we saw before the PATH model was developed, an 83-year-old gentleman who had moderate stage Alzheimer's dementia. He had chronic heart disease and chronic kidney disease, and he had an x-ray done when he had pneumonia, which actually picked up a lesion in the lung, which was found later to be lung cancer. Now, this gentleman is living at home. He has a good quality of life, and the question is, should a man with moderate dementia and a good quality of life have surgery to remove the cancer, which is curable with surgery? So think about perhaps what you would think in terms of approaching that, and I'll go through what ended up happening to this gentleman. So he did have surgery, but he experienced a significant and permanent deterioration in his cognition. And with that deterioration in his cognition, he developed behavioral issues in hospital that needed medication to sedate him. He wasn't able to return home as a result, and he ended up being placed in a nursing home.